Postpartum hemorrhage. So welcome to mini lecture number 2. This should be the last one to go along with our postpartum content. Postpartum hemorrhage is the most prevalent medical emergency that you're going to see in the postpartum population. It is the leading cause of death for women in the immediate postpartum period, especially when you're looking at the first 48 hours after delivery. So what is a postpartum hemorrhage? How do we classify it? So there's kind of an ongoing conversation about this. We used to be really strict in if it was a vaginal delivery, any quantified blood loss greater than 500 mLs constituted a hemorrhage. If it was a C-section delivery, quantified blood loss over 1,000 mLs or 1 liter would constitute a postpartum hemorrhage. Typically, for a vaginal delivery, you're looking at about less than 300 being normal or expected quantified blood loss. For a C-section delivery, you're looking at anywhere from 500 to 750 as a normal expected range. Sometimes they get away with a little bit less. There are some guidelines that say, you know what, it shouldn't be just quantified blood loss. We should really look at the hemoglobin and hematocrit drop from pre-delivery to post-delivery. And they're saying anything greater than 10% drop in those would be constituted to describe as a hemorrhage. But it's not an exact science. And in the moment when a postpartum mother, regardless of the delivery method, is bleeding excessively, nobody is going to stop and say, hold on, let's weigh everything out so we can quantify this blood loss before we do anything. Or hold on, let's draw some labs and make sure that she dropped 10% before we intervene. That is not realistic, and nobody does that. So as a nurse, if you are taking care of a postpartum woman, it goes off your nursing judgment. If you decide her assessment, whether that be from her vaginal delivery or vaginal bleeding amount or her other signs and symptoms, her complaints to you, if your nursing judgment says this is too much bleeding, this is excessive, something is wrong and we need to intervene, then you call it a hemorrhage and everybody goes from there. No healthcare provider I've ever met would say, oh, err on the side of it's probably not until you're really, really sure. Everyone would rather intervene and do more than is necessary and end up with a good outcome versus, oh, it's fine. Oh, it's probably not that bad. Oh, we'll overlook it until you're too far behind the 8 ball and then you're playing catch up trying to save somebody's life. So your nursing judgment tells you if it is excessive, we consider it a hemorrhage and we intervene as such. Now, often the very first sign of a hemorrhage, which is the leading cause of hemorrhage, is uterine atony. This means boggy or soft fundus, okay? And as you get to do some uterine assessments in the simulation lab and in the clinical agencies, you will get to understand what it means to not only assess a fundus, but what the difference in that boggy feeling or firm feeling actually palpates to. So why this is so important in regards to a hemorrhage. Bear with me, I know this is not going to be the best drawing, but the uterine muscle, okay, the muscle fibers are built like a lattice. So you have these muscle fibers of the uterine wall, and they're built like this, okay? The blood vessels that were feeding the placenta prior to delivery, all of this extra blood volume that is really the crucial supportive point of supporting a pregnancy, okay? All of the blood vessels that do that used to be attached to this placenta that is now gone come through this lattice shape, okay, of uterine muscle fibers. If the uterine muscle is boggy, soft, non-contracted, these gaps between these muscle fibers are very open, laxed, allowing for all of those blood vessels to just drip, 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 all of this blood, okay, passively. If we massage the uterine muscle and get it to contract, or we use medication to contract the uterine muscle, which is our goal, right? We want it to contract. All of a sudden, our muscle fibers with that constriction, we still have a lattice shape, but our space in between is much, much smaller, meaning our blood vessels in those spaces have been constricted and much less passively are now allowing blood to seep through. Okay, so this is why it's so important to have constriction of that uterine muscle, and that explains why it decreases the blood flow the way that it does. Again, I know I'm no artist, but for your visual learners, this is the best way I can explain why uterine contraction is so important. Okay, so uterine atony, that boggy or soft fundus, usually, most often, is going to be present with a postpartum hemorrhage. Things that increase the risk for uterine atony include anything that overdistends the uterus. So an LGA baby or a large for gestational age baby. Multiple babies in the uterus, right? Even if they're normal size, if you have 2 babies, that's going to stretch out the uterus more than our typical 1. Polyhydramnios, which means an excess of amniotic fluid. Okay, so an excess amount of fluid is going to overstretch that uterus. So anything that overdistends the uterus increases the risk for uterine atony. Other risk factors that increase a mom's risk for a postpartum hemorrhage include multiparity. So if she's been pregnant 5 or more times, especially, their risk factor is very high for a postpartum hemorrhage. They don't have to be pregnant 5 times to make the risk go up, but 5 plus is super, super indicative of increasing that risk. Precipitous labor or birth. This means that the labor or birth occurred very quickly in a matter of a few hours from start to finish. Prolonged labor, especially if it's the second stage of labor, which we'll learn more about that later. The second stage is the pushing stage. So the longer mom has pushed baby out, that's all that excess pressure to the uterus, and that increases the risk for a postpartum hemorrhage. An operative vaginal delivery, meaning the physician has used either forceps or a vacuum to help mom deliver baby vaginally, that increases her risk. Manual removal of the placenta. This only occurs if the placenta has taken too long to detach naturally to where we deliver it after the delivery of baby. Placenta previa or accreta. This is an abnormal location and or implantation of the placenta to the uterine wall. Induction of labor. So we are careful about our induction plans and how we utilize different methods of induction. Magnesium sulfate use. This is used for moms in preterm labor or those that have hypertensive disorders of pregnancy. And we'll talk about exactly why we use that later on when we get to more antepartum and intrapartum content. But magnesium sulfate is a smooth muscle relaxant. So the uterus being a smooth muscle, if we are giving magnesium sulfate, that uterine muscle is going to be more relaxed, which allows for more space between those muscle fibers. Chorioamnionitis, which is an intrauterine infection, and we know how infection really irritates all kinds of tissues, so that increases our risk for hemorrhage. And then if the mom has had a previous postpartum hemorrhage with a previous delivery, her risk in all other deliveries are also increased. So different assessment findings that you are going to see. Now, the patient does not have to have all of these assessment findings to say she is having a hemorrhage, okay? She doesn't have to check all the boxes. It might be just a couple, it might be all of them. But uterine atony is number 1. Excessive or bright red vaginal bleeding, okay? And we'll talk a little bit about how we assess lochia and what constitutes excessive. Pelvic discomfort or backache. Persistent bleeding with a firm fundus. So we said uterine atony is often the cause, but what happens if our patient is bleeding excessively and the rest of her assessment looks like she's having a hemorrhage, but the fundus is firm? It's not uterine atony. We start to think about lacerations, either to the cervix, the vaginal tract, the perineum. The blood is coming from somewhere. It just doesn't happen to be coming from uterine atony. Rise in the level of the fundus of the abdomen. So when we talk about our normal uterine assessment and what we would expect our uterine involution rate to be, where we would expect it to be given how long it's been since she's delivered, if we are consistently right at umbilicus or a little bit below, and then all of a sudden we're in positive numbers, we've had this increase in size in the abdomen, that's indicative of a postpartum hemorrhage that is occurring or is about to occur. Increased pulse or decreased blood pressure. Usually those two things happen together as mom starts to hemorrhage in response to that loss of blood volume within her circulatory system. So we have that drop in blood pressure because of the drop of volume, and then the heart compensates by increasing its heart rate. And these are initial findings for those. If we get to the point where we now have a decreased blood pressure and a decreased pulse, usually we are in a very late stage postpartum hemorrhage. Maybe we've missed some initial signs that we could have picked up on. The patient is anxious and restless. If we see a perineal hematoma or a vaginal hematoma. So a lot of times this, how we were talking about thinking about a laceration. So the fundus is firm, but there is no laceration. There's no external bleeding, but the patient still appears to be hemorrhaging, losing blood volume somehow. Sometimes that's an internal hematoma that we might not see on external examination. And then decreased level of consciousness, cool and clammy skin. Typically, this is after the hemorrhage has been occurring for quite some time. So hopefully this isn't one of the first things we see, but this is indicative that the patient is losing blood volume. So different causes of a hemorrhage. So we said uterine atony is number one. Now there are different things that can cause uterine atony. Subinvolution just means that the uterus is not clamping down and decreasing in size as we would expect. Also, if the bladder is full, as you can see in this picture here to the right, the bladder and the uterus sit very close to each other. And if the bladder is full of urine, it actually displaces the uterus and gets in the way of it constricting and clamping down on itself. So that can lead to a postpartum hemorrhage. It's one of the reasons we pay so much attention to urinary output and how often a mom is urinating following delivery. Retained placental fragments. So if the placenta isn't completely delivered and pieces are left behind in the uterus, that can and will lead to a postpartum hemorrhage. Again, lacerations and hematomas, and then coagulopathy issues. This isn't as common. This is definitely a less percentage for postpartum hemorrhages, but it can be a cause. So what do we do? If we have decided our patient is hemorrhaging, what do we do as nurses? First and foremost, massage the fundus, okay? Especially if it's boggy or you see, feel uterine atony. Obviously, if the patient's hemorrhaging and you feel the fundus and it's firm, that's not going to be your first action. But given that the majority of postpartum hemorrhages stem from uterine atony, we are going to want to do massage. Massage can firm up that uterus enough to completely decrease your bleeding. Sometimes you can completely mitigate a large hemorrhage from happening by massaging the fundus. Sometimes that's all the patient needs is a little extra uterine massage, and then maybe we follow it up with some medications, and then we've really decreased the severity of our problem. Now, that's not always the case. Massaging the fundus isn't always enough, okay? So if it's severe, so we're massaging and whether we're not firming the fundus up or it's firming, but then it keeps going back to boggy, right? We're not having consistent uterine contraction. We are absolutely going to call for help. You don't want to be the only person in the room managing a postpartum hemorrhage. You can put the patient in Trendelenburg or at least lay the head of the bed flat. This helps with you being able to do adequate uterine massage. And it also helps with providing blood flow to the patient's brain. So she stops feeling, or at least feels less dizzy, or sometimes it helps with their nausea too, just because they don't feel so lightheaded. You open the IV fluids, give her a bolus. Absolutely. You can start another IV, especially if it's severe enough that we're anticipating we might need blood product replacement. Assess for shock. So we're assessing her vital signs very frequently. Most of the time during a hemorrhage, you are assessing about every 5 minutes, if not sooner. Apply oxygen if the patient's SATs decrease, or even if her SATs haven't completely decreased, but she feels faint, she feels lightheaded because that drop in volume, it can't hurt to throw some extra O2 on by mask. Save all the pads for inspection, especially if we're thinking like, ooh, this might be because there's some retained placenta left behind. We want to make sure we inspect all of the products that come out so we can see if there's anything there that needs to be noted. Quantify blood loss. We do this by weight. Okay, so 1 gram of weight equals 1 ml of fluid. Okay, so if we measure all of our pads and all of the lochia that we've saved from this hemorrhage afterwards, and we can quantify that blood loss by weighing it, making sure we're in grams, and then transposing that to mLs, and that tells you your quantified blood loss. Medication therapy, which we're going to talk about more about here in a second. And then there is something called a Bacry balloon. This is an intrauterine pressure device, essentially, that goes inside the uterus. It fills up with fluid and puts pressure on the inside of the uterus to stop, to put compression on all of those open blood vessels and stop or severely decrease the bleeding. Last but not least, if we've done everything that we know how to do and we cannot stop this hemorrhage from occurring, the patient will go back to the OR and they can surgically repair the problem, or sometimes it does end up that they have to remove the uterus altogether if it gets to the point that that's a life-saving measure. Obviously, that's not our goal, but it does happen sometimes. So different medications that we use to manage a postpartum hemorrhage. Our first line is oxytocin or Pitocin, however you would like to remember it. We use this very, very frequently in OB. In the postpartum setting, we use this to create uterine contractions and sustain that uterine constriction. So this can be used to prevent or reverse uterine atony or hemorrhage. So in most institutions, it is per protocol that after delivery, a mom receives 1 bag of Pitocin as just standard ways to prevent further bleeding or possible hemorrhage. We typically give this IV. In the setting of a postpartum hemorrhage, if you did not have IV access, you can give Pitocin IM. You don't see this done a lot in the hospital environment because A, the majority of the patients have IV access, or B, if they don't, there is somebody that is able to get IV access rather quickly on the patient. And IV has a quicker onset than IM. So if we are controlling a hemorrhage or attempting to control a hemorrhage, obviously we want the medication to work as quickly as possible. So our chosen route would be IV. There are no contraindications for use of Pitocin in a postpartum hemorrhage. We also use Pitocin to induce or augment labor, and that's where our side effects come into play. It can cause uterine hyperstimulation. Well, that's not a concern in the postpartum period. We want uterine hyperstimulation if we're controlling a hemorrhage. So that's really only an issue if we're using it during labor when baby is still on the inside. Methergin is typically our second-line medication to try to control a hemorrhage. If it's not contraindicated. The major contraindication for Methergin is high blood pressure because the number 1 side effect of Methergin is hypertension. So if our patient already has high blood pressure, this might not be our best second choice medication. Okay, so this does sustained uterine contractions and can be used to prevent or reverse uterine atony, much like Pitocin. It can also be used to manage subinvolution. So if we are using this in the presence of a postpartum hemorrhage, we are most likely going to be giving this IM, okay? This is not given IV. Never, ever, ever do you give Methergin IV. IM use is pretty standard. If we are using it to manage subinvolution, so this would be for the patient who possibly is at a very high risk of postpartum hemorrhage, or we have managed a postpartum hemorrhage, we have stopped it, and then we want to make sure it does not occur again within the next 24 hours, we can give them PO Methergin to sustain those uterine contractions. But in an active hemorrhage situation, you're going to be giving this IM. Methergin comes in an ampule. So it's the little glass bottle that you have to break open. You have to use a filter needle to draw it up, change your needle to a IM needle to use for injection. And again, our side effect, our number 1 is hypertension. So we do not use Methergin as a first option for anybody who has high blood pressure. The next 2 are kind of used as like third-line medications. Some providers prefer these for specific reasons, but most of the time our first 2 are going to be oxytocin and Methergin. Hemobate or prostaglandins. Typically, if our first 2 things haven't done the job that we would like, then we go on to Hemobate and or Cytotec, which is the next we're going to talk about. Hemobate is given IM. Only IM. The biggest contraindication for Hemobate is asthma, okay? That is because a large side effect is bronchospasm. So if our patient has asthma, Hemobate's not going to be our first choice for them. The best way I can tell you to remember that is Hemobate is the only medication that we're going to talk about that has a B in the name. B is for breathing issues, aka asthma. We don't give Hemobate. That's the best way I can remember it. I hope it helps you to do so as well. Cytotec, okay, this is also used to prevent and or treat uterine atony. A lot of times after we have not managed with Pitocin and or Methergin, Cytotec is given rectally, and it's typically 800 to 1,000 micrograms. Cytotec pills come in usually 200 microgram increments. So usually you're giving about 5 of these. I have also seen them in 100 microgram increments. So it could be upwards of 10. They are small, which is nice, but they do go rectally. Onset is very quickly. The only contraindications are allergy. And then as you could anticipate with a medication that is given rectally, our side effects include diarrhea and some abdominal pain. More recently, in I would say the last 3 years especially, physicians and OB care providers have started to use TXA or tranexamic acid to control hemorrhage. This is typically only used if it is a severe hemorrhage. Our more milder ones, we don't usually get to this point. TXA is more commonly used in traumas or in surgeries where bleeding is uncontrolled, but it was happened upon that this also helps control bleeding in a postpartum hemorrhage if it is severe. TXA is given 1 gram in usually 100 ml piggyback over 10 to 20 minutes, and it's IV. Okay, this has the best outcomes if it's given within 3 hours of delivery, and it is in conjunction with our standard uterotonics. Okay, so we're still giving our oxytocin. We've more than likely still tried Methergin and or Cytotec or Hemabate, and then we add TXA on top of it. We don't usually say, okay, now she's hemorrhaging, we're going to skip all of those things and go straight to TXA. That's not standard use. It's usually used in conjunction. There are no contraindications for TXA with postpartum hemorrhage. And then the side effects are listed for you there, none of which are severe enough to not use them in the event that the patient has a severe hemorrhage. I will say that, like I said, this is a newer practice standard. It is not mentioned in your textbook, I don't believe. And this textbook was just published about 1.5 years ago. So it is really, really new to practice. So you may or may not see that in the clinical environment when you're there, if you happen to see a postpartum hemorrhage situation. So last but not least, aftercare for the mom. After the hemorrhage has been managed, after she is stable, we are going to be reevaluating her CBC, looking specifically at her hemoglobin and hematocrit, pairing those numbers with her signs and symptoms after. Is she lightheaded? Does she have orthostatic hypertension? Is she dizzy, short of breath, those kind of things, tachycardic? If all of those signs and symptoms are present and we had a significant drop in her hemoglobin and hematocrit, she will maybe be a candidate for a blood transfusion. So it doesn't go strictly off of just their CBC counts. Providers take into account not only the drop in numbers, but also the patient's signs and symptoms. And then just like with any other form of treatment, blood transfusions can be declined by the patient. Pain management, especially if they required a lot of internal maneuvers or interventions to stop the bleeding. Education to the patient, especially regarding signs and symptoms to report if she was to have another hemorrhage, and then fall risk due to dizziness if she does have that orthostatic hypotension from that loss in blood volume. And then because of that drop in fluid volume status, we want her replenishing fluids. We can also do that via the IV route, but we always tell moms to hydrate as much as possible, PO. And then thinking about if this mom is breastfeeding in the postpartum setting, which many of our patients are, this severe drop in fluid volume status can have effects on her milk transitioning over and the volume that she has for breastfeeding. So just those education pieces that we might have to intervene on that as well for her and baby's feeding methods. I hope this gave you a little crash course in postpartum hemorrhage, and we will talk more about it in class.